Hello everyone, today I will talk about Lisa Rosebaum's 2017 case study on CAR T therapy. It tells the story of Emily Whitehead, the first child treated with CAR-T19. Her case showed two sides of this treatment. It could remove leukemia when chemotherapy failed, but it could also cause a dangerous immune reaction called cytokine release syndrome, or CRS. Acute lymphoblastic leukemia, or ALL, is a cancer of immature white blood cell called lymphocytes. Most children respond to chemotherapy, but B-cell ALL is harder to treat when it comes back. CAR-T uses the patient's own T cell. Doctors collect the cell and add a gene for chimeric antigen receptor, or CAR. CAR-T19 recognizes CD19, a protein found on normal B cells and most B-ALL cells. A normal T cell receptor needs MHC to show it an antigen. A CAR can find CD19 directly. This makes it target living treatment. The poster shows 6 steps. First, doctors collect T cell from the patient. Second, they add the anti-CD19 CAR gene. Third, the new CAR T cell are grown in the lab. Fourth, the patient receives preparation chemotherapy, and the CAR T cell are returned to the blood. Fifth, the CAR finds the bind CD19 on the leukemia cell. Sixth, signal inside the CAR T cell turn on its killing response. The T cell then destroy the leukemia cell. These CAR T cells can also multiply inside the blood and keeps looking for more cancer cells. Rosenbaum tells Emily's story to explain how CAR-T was developed. Emily was diagnosed with ALL at age 5. Her leukemia came back, and more chemotherapy failed. One doctor recommended hospice care. Her parents chose an experimental CAR-T19 study instead. Emily became the first child to receive this treatment. After her third dose, Emily developed a high fever, breathing failure, and dangerous low blood pressure. She went into shock and needed 3 vasopressors. These are strong medicines that raise blood pressure. An urgent test showed that IL-6, an inflammatory signal, was about 1,000 times higher than normal. The hospital already had tocilizumab, an antibody that blocks the IL-6 receptor. Emily received it that evening and improved within hours. 8 days later, a bone marrow test showed remission. Rosenbaum explains that this success came from many years of research, carefully preparation, and some chance. The article also reported a later phase 2 result. At 3 months, 83% of 63 children who had been evaluated had no detectable malignant cells. This gave us an important lesson. Rapid CAR-T activation released many cytokines. This caused severe inflammation, fever, and shock. The very high IL-6 level gave the doctor a clue. Tocilizumab blocked the IL-6 receptor and claimed the inflammation. At the same time, the CAR-T cell continued attacking the leukemia. Doctors could therefore control severe CARS without stopping the cancer treatment. Emily's case was important, but one success could not prove that CAR-T was safe for everyone or every remission would last. Rosenbaum showed that CAR-T became possible because researchers continued working through limited fundings and failed studies. Important limits remain. CAR-T19 also removes normal B cells. This is called B-cell aplasia, and it means that patients may make fewer antibodies. CRS and neurotoxicity means harmful effects on the brain, can also be life-threatening. The treatment is slow and expensive to make. Solid tumors are hard to treat because they may not have one safe target like CD19. Future studies should test CARs that recognize more than one antigen. Researchers should also add safety switches to make the treatment faster and cheaper. Better ways to treat solid tumor and longer patient follow-up are also needed. To conclude, CAR-T is a powerful living treatment, but doctors must carefully control its immune side effect. Emily's story shows both promise and the dangers of engineered immunity. Thank you.